Record kori record kori. It is fine to do it. Good morning, my dear students. Today we are going to talk something on thoracolumbar spine injury. So far, we have discussed about the cervical spine injury. We have discussed its anatomy. We have discussed various part of its development also. And the mechanism of injury in cervical spine. And also we have discussed about the treatment protocol, how to exclude it. Subsequently, also we have discussed about the radiological evaluation of the cervical spine. Today we go down below to the thoracolumbar spine. As a whole, thoracic and lumbar spine injury is quite common, very common. Very common in two age group, particularly younger age group or active adult, and also elderly age group. Elderly age group basically because of osteoporosis or because of insufficiency fracture, for commonly find. So very often you will get cases coming to you in the outdoor or in the casualty with the history of fall because of your unsteadiness many times, because of weakness, they tend to fall. Once they are falling on buttock, many times they used to fall on buttock. That's lead to the impact of the force on the thoracolumbar area. Now, what is the thoracolumbar area? Actually, T10 to L2. This is called thoracolumbar area. So this is area where there is commonest injury seen. So once it make it a habit in the spine, in the OPD, that whenever a patient is coming to history of fall from height or fall even on the floor, particularly elderly patient, always try to palpate the spine and look for internals. This is very important. Because of the impact which is falling up here, it actually going to do damage at the thoracolumbar area. Why so? It is because of the meeting of the two curvatures. So thoracic curvature, thoracic kyphosis, we all know this is completely somehow different here. So you will find the thoracic kyphosis, lumbar lordosis. Thoracic kyphosis and lumbar lordosis. So this is very important. So that is why while there is a fall there in downfall, then the impact is going to exert its impact on the thoracolumbar junctional area most of the time. It is common because that this area is having the junction of the two curvatures. Sometimes you may get a tenderness in the coccyx also. So you look at the coccyx and look at the thoracolumbar spine. Palpate spine as a whole invariably get the injury tenderness at the thoracolumbar junction. This is a way. Anyway, little bit of refreshing quickly at the thoracolumbar, thoracic and the lumbar anatomy. We have already discussed. So in thoracic area, you will find the joints are anterior posterior in the this plane, coronal plane. That is why in this area, you get flexion extension and to some extent rotation. And most of the time rotation is mostly seen T8 and T9, this area junction. So rotation about lateral bendings and other things are very limited. So you have no, because in it, spine, one rotation is this. This is in C1, C2. And while our body is rotating, it is mostly in thoracic spine, and particularly T10, T11, T9, this area, T18. So you get this one. But other movements are little bit, others are not here. And the rotation is very much limited in the lumbar area because the design is like this, and it is in this plane. This is a plane. So it will not allow you to do rotation. Say it is cervical spine, you have rotation there, another thoracic spine, you have rotation. But lumbar area does not give much rotation. So you can have flexion and extension. To some extent, lateral bending also contribute. But rotation mostly in thoracic spine because of the design of the joint. One point. Thoracic area, regarding we have said about the occupancy is very important of the cord. So the cord occupancy in the canal, we have discussed this thing already while talking about the cervical spine also. The occupancy of the cord in the canal is very good. You'll find the major part of the canal is been occupied. This is occupancy of the cord. We have discussed this thing. Occupancy means the area which is being occupied mostly by the neural tissue. More it is compact to neural tissue, more it is unsustainable. That is common. And that is why you will find in thoracic spine, if there is minor injury also, then the neurological deficit is high. This is very important. Even disc prolapse, although it is very uncommon in the thoracic spine, but a minor non-significant disc prolapse may also cause significant neurological deficit. So that is why this occupancy is recorded. Whereas in lumbar area you will find the canal is too big. Then the occupancy of the cord is less. So you have more space to accommodate. That is very important. That is also in lumbar cervical spine. You have occupancy there, and you can have. So that is why C1, C2, C3 level also there is so much injury, but neurological deficits are less. Thoracic area dangerous. Dangerous because occupancy is small, and it is being occupied by neural tissues. Means you have the meninges, epidural fat, and this thing, and then the cord itself. So that is very important. That is why you will find one thing I will tell you, that in lumbar you will find sometimes significant prolapses there, but there is no neurological deficit. It's simply comfortable. But the MRI says this is very. That is why sometimes there is a confusion whether to go for surgery or not. But do not go for surgery unless there is some neurological deficit is there. Otherwise, no. So MRI should not tell you to go for surgery. In case of lumbar area, the characteristic that we can accommodate more. So that is the basic difference between these two. And you all know about the artery of Adam twist. You must know in lower thoracic you have the vessel, this watershed area. And this artery is very important. While it is very blocked or damage to the artery, there is significant damage to the nerve. Sometimes we get people are coming without any, everything is normal, but neurological deficit is there. Probably the region is very vascular. Probably the incidence is very less. But even then there is a possibility there. Everything you have done, all investigation will fail. Probably this is the result of your vascular. And vascular, most of them are. And then surgery also is very important. That part you have to be careful. The artery should not get damaged. Sometimes you may get a sort of also. Artery is coming, which area, though it is variable, but it is mostly the thoracic, lower thoracic area it supplies. And this is entirely dependent on the artery. So you know the anterior spinal vessel, posterior vessel, all are there. But this area is significant. Now these vessels are being tributaries are there from the intercostal vessels and other thing also. Here you have to be careful that you do not damage this here. That is important thing you have to understand. And also now what is the what is the mechanism of injury? As already told you, the mechanism of injury in the cervical spine and thoracic are more or less same. More or less same thing. So exaggerations of the main movement, the flexion, extension, lateral bend, lateral rotation. Exaggerations of this crossing the limit also cause the damage. We already discussed about the flexion injury, flexion distraction, axial compression. These are already discussed. Same thing here also. Then extension injury. Yes, extension injury. Then here is a combination of the flexion and sometimes rotation. Yes. So the mechanism of injury more or less is same with that of your cervical. So excessive cervical, supposing there is a flexion, too much flexion, what will happen? Too much flexion means lead to your, so this vertebra C. This is like this. Too much flexion will lead what? Too much flexion will lead to compression of this area. The vertebra like this. So I told you that the excessive movement in the same thing, same movement, if it is happening more excessively, that is detrimental. And there will be pure axis or it will be combination. That is to understand. Sometimes the force may work compact like this. Like this, most of the time we have seen a fall outstretched, fall on the buttock, fall from height, axial. Yes or no? Then you may get a seatbelt injury, then again steering force. Yes, one is this. But I told you that there will be combination of this. Combination means axial plus rotation or flexion with rotation. And flexion with rotation may happen. Or purely sometimes rotational injury also, purely. So it may happen. So try to understand the basic mechanism are same. And pure axis, flexion, extension, lateral mean pure axis, or combination of this may lead to your various consequences. Try to understand. Now, if there is a flexion injury, same thing happen. If there is there, what will happen? There will be compression here. Yes or no? If there is more and more compression, there is distraction on the posterior side. So PLC will be injured. Yes or no? So if it may one time go sleeping also like this. So it may go for dislocation also. Yes, sir? So necessarily in this situation is a stable or unstable. The unstable situation. So again, stability and instability question, as you know, we have Dennis column 3. We have discussed this in anterior column, middle column, posterior column. If there is more than 2 columns involved, it is unstable. And particularly middle column is involved, it is unstable. And stability and instability, as I said already, is dependent on this area unable to withstand the physiological load. Physical load, not doing anything, but his own load cannot be withstand by this area. It's called instability. So instability is most of the time is because of the injury of more than 2 columns. And that is 2 column is posterior anterior column, or even if they are already pure middle column is involved, it is also constable. So instability defined like this. Anatomically is this, and this is a situation where you need to intervene with many times with surgery because it is unstable. But as I said, what are the things may happen? One is this compression, and vertical compression may lead to your burst fracture sometimes. Definition of burst fracture, there are 2 types of burst fracture. One is stable burst and unstable burst. Stable burst, unstable burst. Stable burst, unstable burst is dependent upon the involvement of the PLC. Yes, sir. So here now again the compression fracture, which let us talk about the compression fracture, then we will talk about the fracture, burst fracture. Now, I said these are the commonest fractures. What are the commonest fractures actually I'm going to? One is the compression fracture. Yes. Another is your burst fracture. What is that? I'll tell you. Another fracture, dislocation. Yes. Yes. Okay. Now let us talk about the compression fracture. Now, as I said, compression fracture is basically flexion injury. Understood? If the compression is taking place in one side, there may be lateral compression also. Yes, then this compression leads to a compressional fracture. Now, what are different types of compression may take place here? One, compression may cause the fracture of the both end plane. One. Number 2, it may only cause a compression fracture of the superior end plane. Yes, got my point? Number 3, it may involve the inferior plane. Number 4, both the places are intact, but there is compression of the body. Okay, sir? So compression is also again different. Compression fracture may lead to involvement of both the upper and lower end plane. Both are broken. Okay, sir? One category. One category is that there is upper end plane is involved, lower end intact. Okay. Yes. Then you will find the lower is now involved, upper is intact. Now one other group you will find the both are intact, but there is compression of the body. Fine. The end plates are very good. This sort of combination of injury with the flexion. Again, these fractions may go for significant fraction and an unsignificant term. What is significant fraction is that if the fraction compression is more than 50%, it is a unstable type, it is a sign of instability. Okay, sir? I am talking many things in relation to compression itself. Compression fractures, what are the things may happen in the compression fractures? Okay, sir? In place environment, body, yes. Then again, I have said if the compression is more than 50% of the work, that can be calculated with the help of the adjacent vertebra. The adjacent vertebra is this, and it is coming down. So more than 50% compression is dangerous. Dangerous when you say in place, because if it is more compression, necessarily the posterior side is opening up. So opening up means it's also equally causing the injury to the PLC, posterior ligamental complex. If the anterior part is also compressed significantly, equally posterior ligamental complex is also distracted and injured. So this anterior and posterior both are involved. This is a potentially dangerous. It is a unstable reflex. Understood? And finally, it may go for your dislocation also. So the extremes of your flexion injury, see, so many things may happen to it. Got my point? So many things may happen to the flexion injury. Another is a vertical that lead to most of the time the burst flexure. So burst flexure sometimes may cause injury to the BPLC, sometimes may not. That is why these are the two types. One is your stable burst, other is unstable burst. Stable or means you have ligamental complex more or less integrated, stable. The ligamental complex involved is unstable. So there are two types of stable. Got my point? In the flexion injury I have discussed, told you what are things may extreme or a simple up to the extreme state. What are the things may happen in flexion? Vertically, this most of the time your burst flexure, and definition of burst flexure there while the canal is involved. That means posterior wall is involved and there is a break in the posterior wall and fragments are going to spin. Okay, sir? Your definition of burst flexure and compression flexure do not have confusion. I told you repeatedly. So if it is so, now this burst flexure is happening, it may cause the compression on the cord from the posterior wall. So the canal may be compromised in burst flexure. Okay, sir? Another group in burst flexure is there, but it is a very stable type. You don't need to go for something more. So it can be treated conservatively also. Yeah, again, now extension type. One is the seatbelt injury. So you'll find there is two types of sense flexure. One is that it is there is flexure at the body and it is going posterior like this from the bone. Sometimes this shearing force may be there in the disc level. Okay, sir? One is bony sense, one is a non-bony sense. In the sense that sometimes there may be a fracture there throughout the body and going to the bony end. The same thing may happen in the disc area also, leading the same sort of picture. So this is no involvement. Okay, sir? It is hypertension. So then they also translation nowadays. Now one thing I have to tell you that there are many classifications in thoracolumbar spine. None of these are very much comprehensive and unable to satisfy all the criteria. And sometimes there is no relationship with the compression with that of the neurological deficit. Direct relationship is not there. Somewhere you may find, but somewhere you may not find any sort of your morphological injury cannot be related to your neurological deficit. Understood my point? So a morphology is this. This morphology cannot tell every time that if the fracture like this will be neurological, nothing like that. There may not be correlation. May be correlation, may not correlation also. So that is why it is very difficult sometimes situation. The deep if this fracture is there, if is significant there should to be vice versa, it may not be, or someday you will not find so much injury, but there is a neurological deficit also. Reversing may also happen. So this morphology doesn't reflect the neurological deficit. Okay, sir? So from the X-ray, you cannot tell that this may happen. You may predict that this is compression, there is a point. But mechanically, from morphological point, anatomically, you can say stability and stability. This is okay. Unstables are potentially dangerous because they are potentially going for your losing deficient things. Because of movement and things, they are potentially dangerous. That is why I need to do stabilization. That can be reflected with this devices, with this mechanism injury can be said that is stable or unstable. But does not tell you actually the neurological deficit is a different thing. May not have correlation, may have correlation, something. So that is not always fixed. Okay, sir? Then one is your translation laterally also. This is a AO classification. So one is a metric classification, another is your Dennis classification. So many classifications here. And today's scenario is that there is a combination of criteria they are following that say so many things are happening there. Now ultimately while the patient is coming to you, the two things are you have to go. Whether I am going for conservative treatment, whether I am going for operative treatment. Yes, sometimes very much confusing. People may say that I will go for operation here, signs of instability there. Okay, fine, from that point of view you can say. But it is not always uniform. That is why there is a criteria nowadays coming up, a Thoracolumbar scoring system, injury scoring system, Thoracolumbar injury scoring system. That scoring systems include three things. See, this is now I am coming about the grossly how treatment protocol is being designed. The protocol of treatment design, as I said, so many fractures may take place, flexion, extension type injury, or translation. Yes, ठीक है sir. And your burst fracture, so many things may happen, dislocation, or so many things may happen. Ultimately, there is not very much good consensus to determine that this patient needs surgery, this patient not need surgery. So that is why nowadays a criteria is being coming up to give this scoring on the basis of 3 points. One, morphology of fracture. What morphology? As I said, whether the compression is the how much compression? If burst fracture, how much burst fracture? Yes. So if there is upper end plate, lower end plate, and dislocation. So there is number. You have to give the number like the 1, 2, 3, 4, 5. Okay, sir? Most stable is the only compression and most unstable is translation. Okay, sir? That is morphology. So morphologically you have to give number 1, 2, 3, 4, 5. Next is your neurology. Neurology. So you have to get so the neurology intact, root is involved, motor is involved, frankel bleeding, ultimately complete paraplegia or paraipnea. So again go 1, 2, 3, 4, 5. Okay, sir? Got my point? Number 3 is your involvement of the PLC, ligamental complex. That can be determined with the help of MRI most of the time. One group where it is intact, another group where you are unable to determine, another group is where there is definite injury. So see, so as I say, I am talking in context to the treatment also. Two things I am talking. Two things I am talking that I say, what are the possible common injuries may take place in thoracolumbar area? And what are the extremes of injury and common injuries mostly? Most common injuries I find. Classification, they are controversy, but AO classification is now being considered. Depending on AO classification, A, B, C groups are there. Compression fracture, and also become the C is the translation. If the translation is there, translation is there. Okay, sir? Dislocation, translation. So they have three groups of your division. Besides, earlier people also make reclassification. Then again, you say the Dennis classification is also various types of classification. But as of now, AO classification is universally accepted as of now. Okay, sir? AO has 3 groups of classification, A, B, C. That is the classification of the thoracolumbar spine. Then I am talking about that after this, you have to give treatment. One group you can treat only conjunctive treatment most of the time, rest, brace. Most of the time, rest and brace. Another group you need to go for surgery. Determination of surgery is a very controversial one. That is why this criteria is coming, thoracolumbar injury scoring system. That injury system, as I said, is to tell us that we go for conjunctive treatment here, we go for here. That division is mostly done with the help of your scoring system. That scoring system includes three things. One is morphology of the fracture. How is the fracture? Up to dislocation, grading is more. Only compression, grading is 0. Very stable here. Got my point? That is 1. 0, 1, 2, 3, 4, 5. That is from morphology. Number 2, gradings are only basis of neurological. One group, there is no neurology. Another group, only root is involved. Another is motor is involved. Another is motor is involved. Sensory is involved, like the Frankel grading. And then sensory and motor, but partial motor is involved. Another is complete, what I can say. So this is correct. Number 3 points are the PLC, involvement of PLC. Then how much is involved? One group intake, another group undetermined, confused, have injury or not injury. And third group is there is complete disruption of the PLC. So more the grading means more the chance of operation. So 5, 5, 5, 6, 7 months only have a person. So they used to go for things like this. So nowadays this criteria is very important to determine the final treatment course for thoracolumbar spine. Whether I will go for operation and whether I will go for non-operation. Again, in the operations, there are two conditions. Whether I will go for long segment, that means adjacent to vertebrae short segment. One, if I involve you one above, one below, that is long segment. Long segment where and short segment, another is surgery. That is another determining factor to go for whether I should go for long, whether I should go for short. Okay, sir? Outline this. Now, then one group of patients may come to you with a history of fall, then there may not be anything here. So you have to exclude them. In a cervical spine, I also told you that all the injury may not need to go for radiological evaluation. Radiological evaluation may not need. So radiological evaluation exclusions criteria in the cervical spine we have mentioned. Same thing is applicable for the thoracic spine. Fall there, then you may think that there is an injury possibility in the thoracolumbar spine, but not necessarily they may be injured. They may fall but may not have injury. So in the casualty, you have to determine if you have to then what you are going to do, how to exclude. Then unnecessarily putting the patient for investigation is no logic. So that is why you need to exclude him. And how to do the exclusion? The palpation, you will find everything is smooth. The contour is okay. There is no tenderness. Patient is conscious. There is no neurological deficit and can able to have good range of movement at the thoracolumbar spine. This is called exclusion of thoracic spine. Same thing I have discussed about the cervical spine. So if the patient is conscious, non-intoxicated, no neurological deficit, can able to do good range of movement, and there is no tenderness in it, you can exclude. That I do not need to go for investigations. Same thing here also, thoracic spine also, I need to exclude. Because all the patients may not need X-ray or investigation. Yes or no? So that is why to exclude it, you have to exclude it. In the practical scenario, then I am doing so. And another group, you have tenderness. In the tenderness group, there are two things. One, associated neurological deficit, another without neurological deficit. Yes or no? If there is neurological deficit, then you have to determine whether the patient is in spinal shock or without shock. Yes, if his shock is over, then you have to evaluate the neurological status and categorize according to ACI grading, ACI, ABC. And Frankel grading also almost same, the normal and appropriate place. So that is neurological. Then you have to left behind the X-ray. What are the investigation you have to do? Normally you have to go for the same plain X-ray. Normally. But plain X-ray in the emergency situations are not very much good enough to give actual heavy picture, but sometimes gross injury can be seen. But to have better evaluations, one should go for CT scan. And as I said already, there is every possibility to non-continuous or non-congruent area. That means one can have injury in the cervical spine as well as injury in the thoracolumbar spine. So that is why it is always mandatory to look for the spine as a whole, so they do not miss the case. Around 10 to 15% cases, sometimes even 20% cases may have more than 2-level injury, more than 1-level injury. So that is why it is important. Equally, also one should go for MRI. MRI is going to tell you about the possibility of the compressions of the discs, particularly soft tissue. And most important thing is the PLC. What is status of the posterior ligamental complex? If the posterior ligamental complex is injured, probably it is a potential case of instability. So in these situations, you have to predetermine that though there is no neural deficit, this patient may need surgery on the basis of this pain. So it is not only the neurological deficit that determines, sometimes without neural deficit, a patient may need to go for surgery, depending upon these factors. So in the nutshell, so thoracolumbar spine injury is this. You have mechanism of injuries almost same with the cervical spine, as I said. Then you have to understand the common injuries are mostly the flexion injuries, as I said, and compression fractures, and the extreme of compression fracture up to dislocation may happen. Yes. Then again extension type of injury, then vertical compressions, and so many things happen. So in this situation, so you need to understand. Then the evaluation of the patients in the casualty setup, how to evaluate it. There are exclusions of the patients on the basis of the clinical finding. That I need to go for an investigation. One group we need to investigate. Plain X-ray is not always very sufficient. We need to further investigation by CT scan. Particularly, CT scan is more important to speak about the exclusion from the compression fracture that of your burst fracture. Sometimes it's difficult to determine with the head. But the AP view of the spine is very important to tell you burst fracture. So interpedicular distance is very important. If it is more, say X-ray. So X-ray, if you say that there are so many things happen in the X-ray also. As I say, radiologically, one can determine plain X-ray also that whether it is unstable or unstable. As I said, one of the criteria is that more than 50% reduction in vertebra equally indicates that there is disruption to the posterior structure of the PLC. It is unstable situation. Yes, if the reduction is only 25%. In cervical spine, 25% is very significant. But the thoracolumbar area, 50%. Then the curve angle also, if it is around 20 to 30 degrees. I will tell you how to determine the curve angle. That curve angle is more than 20%. So radiologically, one can say the curve angle is 20-30%. One, height is reduction is, then posterior spine is opening up, unstable side, radiologically. From the X-ray. And the X-ray also interpedicular distance. Determine the above and compare it. So if the space is more, that indicates that there is a fracture and it is a burst fracture. That is why interpedicular distance is important. So reading the X-ray is also very important. And most of the time we go for the emergency X-ray, but it is true many times it doesn't give a very good information, the complete information. That is why you need to go for further steps to go for CT scan or MRI sometime. As I told you, CT scan should scan whole spine so that you do not miss injury on conjugate area, other area. And equally also MRI is important to evaluate, particularly PLC and the status of the discs, how the soft tissue structure, how it could injury. Because these are the factors which cannot be seen with a sample X-ray or CT scan. So then you have to determine that I need to go for a person this group. As I told you, this is the criteria you have to fulfill. Then I need to go for surgery here, and I need to go for conjugal treatment here. If I need to go for surgery, then I may need to go for short segment or long segment. Some nowadays people are going for the posterior pedicle screw fixation. But in certain cases, people used to go for anterior also, dual, both anterior and posterior. But most of the time, most of these trauma situations can be dealt efficiently from the posterior pedicle screw fixation because anterior exposures, its mobility is high, complications are high, and people are not comfortable also many times. So it is most of the time it is the posterior instrumentations that give better result. And today's scenario it is the pedicle screw fixation. Though earlier Hartz rectangle, then your Harrington rod, or leakage technique, so many things are there. But evolution is taking place, and today's scenario worldwide acceptable technique for fixation from the posterior side is your pedicle screw fixation that gives better result. And along with this, there is controversy also whether go for fusion or not fusion in trauma situation. There are certain things are very controversial. Even then, basic things are like this. This is in nutshell about thoracolumbar spine. Do you have any question? You can ask.